The next speaker, that is Kjersti Engan. She is professor in information technology at the Department of Electrical Engineering and Computer Science at the University of Stavanger. Her research focuses on signal processing and image processing, machine learning, and their applications in medical field. She leads the Biomedical Data Analysis Lab at UES, where she collaborates with local and international hospitals and companies on different projects. She's a senior member of IEEE AAIA Fellow and member of ELLIS and NUBIM. And the title for her speech today is From Newborn Care to Tissue Samples. How can AI be of help? Please.
Thank you so much, Tom. I would just add that I have also a 20% position at Lardal Medical, so I put them up here. And I put up the logo also of Stavanger University Hospitals, because everything I talk about and almost all I do is in collaboration with them. So AI in healthcare, why do we need that? So similar to what previous speaker was talking about, there is a lot of challenges in healthcare. Some of them are aging population, disease incident rising, especially things like Alzheimer, cancer disease in Western world. We do not have enough hands. We don't have enough nurses or medical or healthcare providers in general, not in the high resource setting and not in the low resource setting. And those who are there often complain about endless documentation needs. And one thing is, for example, in radiology and digital pathology, there has been an explosive growth in both in the overall data volume, but also in the per specialist workload. Meaning, during the last couple of decades, the number of images that we produce in hospitals is going through the roof, but the number of radiologists and pathologists are approximately the same. So this means that we have to work differently, we have to work smarter, and we, maybe AI, can help giving good tools that makes it possible to work smarter. So I'm going to talk a bit about digital pathology or computational pathology, where we start with if you have to remove a tumor or do a biopsy, you remove a tissue from the body. Then that tissue has to be fixated or is prepared, cut in thin slices, put on a glass slide. Traditionally, that would be examined by a pathologist with a microscope, but during the introduction of microscopy scanners, we can make like really high resolution images, or what we call whole slide images. That was the introduction of digital pathology. And with digital pathology comes computational pathology, the possibility of using tools like image processing or artificial intelligence to process, to interpret, to visualize, make predictions on these images because they are digitized. And that the reason to doing that is, of course, that we want to give value. We want to make the workflow more efficient, or we want to be able to give a second opinion, maybe introduce less observer variability, or learning completely new things about the disease also. It was mentioned by the previous speaker that there is a lot of products coming in, that most of them are in radiology and not very much in pathology, but it's coming, like it's on its way in. These images are really, really large. So this is a urinary bladder cancer tumor, which is looked very chaotic because it's a papillary tumor and then you slice in the middle of it. So these are gigapixel images. One image is more than 1 gigabyte. They're pre-stored in these different resolutions so that it's possible to zoom in and out rapidly. If we zoom very far in, if you see in the original image it's just a tiny little spot, then we can see the cells of the tumor. But we can also see like this blood area over here, and this folded tissue here, and burned tissue over here, and this connective tissues. which is maybe not that interesting. I'm going to come back to that. Just remember that. But first, let's jump into cats, as we said. People working with AI, and especially in computer vision, they love cats and dogs. And the classical problem is an image. You want to go from image to class. What is in this image? So then you would feed your entire image into a feature extractor, which is hopefully of this embedding. If you have trained your algorithm well, or your model well, then cat images will be close in this feature space and far away from dog images or bicycle images or whatever else you could have. And then it could be easy to put some layers on to do a classification to make that, to say that this is a cat and not a bicycle. But when you come to these super large images, as whole slide images are, we cannot feed the entire image in one go. So what do we do then? The typical thing is to patch them up in smaller pieces or tiles or patches. And then you can, of course, look at one patch and do some AI or prediction or image processing on that. But you can also try to do what I've tried to show here, where you put all the different patches into this sort of feature extractor, and you get many embeddings, one for each, and then you try to aggregate them somehow. And this aggregation can be done in different ways. We can also have attention-based aggregation, where you sort of highlight what was important and so on. But then finally, you can get a classification. And this is called multiple instance learning, when this system is learned that way. And it's what's mostly used in computational pathology, especially when you want to get one type of cancer grade or prognostics out from an entire slide. But wait a minute, we were just talking about how there was these artifacts and different things, folded tissue and so on, in the slides. And when we start to patch them up, we can have patches that is just rubbish, in between patches that is actually tumor tissue. So how can we deal with that? And that started a line of research that we've been doing, collaborating with the Stavanger University Hospital and others for a number of years, where we try to, prior to trying to say something about grading or anything, it's like, what is the interesting tissue here? What is the tumor tissue versus damaged or other types of tissue? Or what is the artifacts? What is the folded? What is blurry? What is artifacts of blood? And what is actually artifact-free? So this whole line of research we've been doing here is meant as like a pre-processing step. But we've been training artificial intelligence algorithms to do that, patch by patch, saying what is here. Is this artifacts or not? But of course, again, this is just the first step. We have also worked on actually grading tumors. Again, this is urinary bladder tumor, where we have started with doing that tissue segmentation that we just had on the previous slide, saying, okay, let's only look at the artifact-free urothelium. And then, again, we divide that into groups. The groups are patched. We do this type of multiple instance learning that I talked about, aggregation both at patch level and group level, to get finally to some sort of grade. And then by doing this aggregation and attention, we can see where in the image the model spent the most attention to come up with the grade that he got. So grading is something that we can base on the image itself. We know that that's what the pathologists do. It looks at the image and decide which cancer grade this is. So we know that the information is there, and we get reasonably good results with this. But what if we can predict something about the future? Hopefully causal, and not just a shortcut. So we try to do that as well. We've been trying to look at, can we predict if this patient will respond to the treatment, or if the cancer is going to come back, and will it come back in the worst stage? So that's a much more difficult task, because we don't really know if all the information is there in the image, but it might be that we can say something there. And if we can say something from the images, could that even help us learn something new about the disease? So we've been, again, after doing this tissue segmentation, getting rid of damage, having control over tumor and connective tissue, we were playing around with trying to look at different groups, just the tumor, including the connective tissue, just the borderline around it, and so on. What is the most important thing? And we ended up with what gave us the best results in trying to predict whether or not this patient would respond to treatment is to look at not only the tumor, but also the connective tissue, which maybe is logical, because if the tumor is penetrating into the connective tissue, it is a sign of being in a worse stage. So we think it's kind of reasonable. But of course, it's not as good or as high accuracy prediction as for grading. The trends now in foundation models, in computational pathology, lies a lot on foundation models, where many people or many labs with high computational resources have been working on making these foundation models that are trained on very large amount of data, pan-cancer, so multiple different cancer types, trained with self-supervision. And the idea is that they make something that the feature extractor part is more general, so you can use it for your different tasks. Maybe you can do some adaptation, low-rank adaptation maybe you can add some classifier in the end for a specific task. But the idea is that these foundation models can help you to get quicker to a solution that works for different types of cancer. There's also trends in using generative AI in terms of helping with report generation and data augmentation, and multimodal AI, which is combining different modalities. So in computational pathology, we see combining the images, but also with clinical records or with biomarkers and other types of information in doing prediction, especially in doing prediction of prognosis and things like that. Yes, I think that will sort of conclude my computational pathology part, and now I'm going to move over to a very different thing, which is newborn care. And I would say I'm so lucky to be part of this great Safer Birth Network. It's a research network for many years, and it's a large research network with both hospitals and companies like Lærdal and hospitals both like Stavanger University Hospital, but also hospitals in other countries in both low and high resource settings. As many as 10% of newborn need some sort of help to start breathing, and approximately 3 to 5% of them need actual ventilation or resuscitation, as shown here on the picture to the lower right. The first of these projects that I was involved in was from Tanzania, the original Safer Birth project, where there was data collected from admission, from fetal heart monitoring at birth, and from resuscitation. And many medical doctors did their PhDs in this project as well. But from the technical point of view and for our contributions, we are playing around with these signals and video and machine learning, artificial intelligence to look at different questions, like can we predict who would need resuscitation? Can we predict who will survive or be admitted to newborn care, intensive care? Or if we can we say something about what was important for survival? And we could, both with our methods and also with the medical research that was done. We could see that how quickly you start with ventilation is very important. How much hands-off time or how long sections of ventilation that is ongoing is important. And all these things led us to another project in this family of projects called Newborn Time, which is just ended now. We finalized it in August. So newborn time, improved newborn care based on video and artificial intelligence was a collaboration with University of Stavanger, Stavanger University Hospital, Lærde Medical and BIT Unitor, funded by the Norwegian Research Council. And here we did thermal video filming of at the delivery rooms during birth. Thermal video for privacy concerns, both from mothers and healthcare providers. And then we did visual light cameras at resuscitation station, trying to limit the field of view so that we only got the baby and the treatment, the hands of the healthcare provider. And what we wanted to do here was to make this auto-documentation of what is going on during if a baby needs resuscitation. And since we said it was so important how long time it took from baby was born to start a ventilation, this knowing the exact time of birth became very important. So that's the whole reason for doing the thermal video at the labor rooms. So using artificial intelligence, we developed artificial intelligence algorithms to extract the time of birth, to extract the different activities during the resuscitation. This can be done for auto-documentation, combining it with status of the baby and other signals. We can also extract knowledge on what's working well and not, and using it in data-driven debriefing, quality improvement tools, and real-time decision support maybe later. So here we see an example of ventilation, stimulation, and suction done on a mannequin, just to show you how similar the activities can look with this this is done at SUS. One of our algorithms where we had sliding window over the video, finding region of interests, and using the region of interest to sort of predict what activity is ongoing. It works okay. It doesn't work perfect, but it's much better than not having any documentation at all, which is the status of today. And the clinician is, or not, the medical researcher is nodding over there. So, and then from the birth situation, we have more than 1,000 videos from birth, 8 different labor rooms, operating theatre, and all from Stavanger University Hospital. I said that the reason for using thermal cameras is the privacy concerns from the mothers and healthcare providers. But you also see here, we see just the second of a baby being born. We also see that the baby is warmer, coming straight from inside the body of the mother. So it's sort of lighting up in these thermal videos. Makes it also easier to find. But the data, knowing your data is very important, and we needed to do a special type of pre-processing to be able to continue with this because of all auto-calibrations and things that was done. We did image by image, is the baby in the frame or not? And then we did a video sliding window for finding the action of being born. Putting these together, fusing features at feature level, fusing at decision level, we finally got to the point of having baby time of birth detection. Am I over time?
Yeah, we are almost there. You can please continue.
Okay, yes. We did a pilot at the hospital, more than 300 birds pilot implementation, running locally at SUS on edge computer. We detected 100% of the birth and 94.3% within a 10 seconds offset, and with a median offset of 1 second, which we think is pretty amazing, so we're pretty proud of this. And we did some explainable AI to be sure that we knew what we were looking at. So we were asked, when we predict if the baby is in the picture or not, we could see from our explainable AI algorithm that the attention was right on the baby if it predicted that the baby is in the image. So we're pretty happy about that too. Newborn time is finished. Now it's the Safer Birth Scandinavia Plus. We will continue with our algorithms and the collaborations, and now it's with 10 Nordic hospitals. So we're looking forward to the continuation of this. And that is my final slide. I always want to end this by saying AI for good should also strive to be green. Thank you.
Thank you.